Hello everyone and welcome back to Medi Notes for Medicos. The topic that we're going to deal today is about enteric fever. So I have given a picture of a lady known as Typhoid Mary. There's a very interesting story behind this. It is like this lady known as Mary Mallon was a cook over in New York City. During that time, in the year of 1900s to 1907, an outbreak of typhoid or enteric fever had broken out, and she was a positive, strong carrier of typhoid who infected around 50 to 122 people during those days. So, the objectives we're going to deal today is about the introduction, morphology of causative agent, pathogenesis, clinical features, complications, lab diagnosis, prevention, and treatment. The introduction is this enteric fever has two names. One is it can either be typhoid or paratyphoid, and the causative agent can either be Salmonella typhi or Salmonella paratyphi. The mode of transmission is contaminated water and food. The incubation period is around 7 to 11 days, but it can also range from 3 to 56 days. So we have three sorts of carriers of enteric fever or typhoid fever. The first is known as the convalescent carriers. They are the patients that continue to shed this bacilli in the feces for around 3 weeks to 3 months post their clinical cure. The second one is the temporary carriers. They shed this bacilli for more than 3 months to less than 1 year. And next is the chronic. They shed bacilli over a year. So knowing the carriers is important so that during a endemic case or or non-endemic case comes, we can evaluate how a person can infect another. So next is the morphology of the causative agent. So uh, Salmonella typhi actually is a rod-shaped negative gram-negative bacteria. They are arranged in pairs. They are motile and they have a peritrichous flagella arrangement. They are of the size of around 1 to 3 micrometer into 0.5 to 0.6 micrometer in the size. They are facultative anaerobes, but actually they are aerobic in nature. They are non-sporulated, not capsulated. Along with that, they oxidase negative. They produce hydrogen sulfide in triple sugar iron agar. They form black precipitate when hydrogen sulfide is produced. Next is the pathogenesis. So, how does this enteric fever occurs in a human being? So, when a human being they ingest contaminated water or food, they are ingesting the bacilli along with it. So, this bacilli they attach along to the microvilli of the ileal mucosa in the gut, and from there it penetrates to the lamina propria and submucosa. Now, actually, there is supposed to be a phagocytosis by the polymorphs and the macrophages, but this Salmonella typhi or Salmonella paratyphi, they resist against this intracellular killing occurring over there, and they enter the mesenteric lymph nodes and multiply. And after the multiplication, they enter this bloodstreams via the thoracic duct. And next is the clinical features. So the onset of this disease would be gradual. In the first week, you'll be seeing fever, headache, myalgia, relative bradycardia, constipation, diarrhea, and vomiting in children. In the end of the first week, you'll find rose spots on the trunk, which is uh, seldom visible in dark-skinned appearance people, and it can be faded on pressure. Then we have splenomegaly, cough, abdominal distension, diarrhea. In the end of second week, if it is untreated, it can cause delirium, complications, then coma and death. So when they say about complications, let's know what are the complications of this. When we go for the bowel side, we find bowel perforation and hemorrhage. In septicemic foci, we find bone and joint infection, meningitis, cholecystitis. Toxic phenomena, it causes myocarditis, nephritis. In chronic carriage, it causes persistent gallbladder carriage. In lab diagnosis, we take the samples of blood, urine, stool, or bone marrow. So, amongst every sample, the blood sample is the most important. However, we take the urine, stool, and the bone marrow too. So in microscopy we have gram staining, and as I said already, the description, it is those sort of things are the things that we are going to see under the microscope. Now we have the blood culture. So this blood culture, it is incubated at 37 degrees Celsius in McConkey agar, and here we see pale non-lactose fermenting colonies. And because the salmonella, we already know it's motile, but here it is indole and urease negative, and it ferments with glucose, mannitol and maltose, but not lactose or sucrose. So it should be only declared negative after 10 days of incubation. uh, this slide agglutination is the way we can identify the isolate, and the alternate blood culture is by clot culture. Next is the feces culture. Over here we will be directly plating the feces in McConkey or deoxycholate citric agar or Wilson Blair's media. On DCA and McConkey, they appear as pale colonies, while on Wilson's Blair's media it appears as green colonies. If we are if we are applying it in enrichment, the specimens are inoculated into one tube of selenite and tetrathionate broth and incubated for 12 to 18 hours before the subculture onto the plates. Next is the urine culture. Here, clean voided urine samples are centrifuged and the deposits are inoculated into enrichment and selective media as for the fecal culture. Next is the bone marrow culture. In bone marrow, it yields positive even if the blood culture over here shows as the negative. So bone marrow culture is the most relied lab test. Next relied test is the Widal reaction. The Widal reaction, they test for the measurement of O and H agglutins. So if it is in an endemic region, if the titer of OH is greater than 180, then we say that the patient or the individual is infected with enteric disease. But and if the TH is 1 is to 160, then we will say it as infected with enteric fever. However, in cases of non-endemic regions, a titer less than 80 also is applicable. Next one, we see about the other serological tests. We can use indirect hemagglutination, CIE, ELISA, and there are newer methods of detection. One is IgM detection kits. In this, we have two sorts of new methods. One is ideal tubex. In this, we use the test tube and the serum that we collect or the blood sample that we collect, and within 3 minutes we get the within few minutes we get the results. The next one is the typhi dot. This is a rapid serological test that gives result within 3 hours. Next one is a slide test. In a slide test, we get the color antigen agglutination with specific bodies in patient's serum. Next is the other lab test. We can do a CBC, we can do a diagnosis of the carriers, then we can do the salmonella isolation by the filtration through multipore uh, multipore membranes. Then we can do the typing of Salmonella typhi. We can either do the bacteriophage typing. In that, what happens is we can help to know the source of the epidemics, and we can provide the information on this patterns or the trends that is causing this of the epidemiology of the typhoid at the local or international or national levels. When we go for the molecular method, we can use pulse field gel electrophoresis, or we can use multi-locus enzyme electrophorese, IS-200 profiling, random amplified polymorphic DNA analysis. Now we'll be looking into the prevention. So this is a CMI, cell-mediated immunity. It develops during the course of the infection. We can prevent it by improvement in the sanitization and provision of safe water supply. Also, there are vaccines available now. The first one is the TAP vaccine. We give 2 doses of 0.5 ml each, 4 to 6 weeks interval. And because it's a killed vaccine, it does not provide cell mediated immunity. Next, we go for a live oral vaccine. Here we give this vaccine 1 capsule oral 1 hour before food with glass of milk or water on days 1, 3 and 5. So this is an enteric coated capsule which is 10 to the power 9 viable lyophilized mutant bacilli. And the next one is the VI vaccine. This is given as a single subcutaneous or intramuscular injection, and it has minimal local reaction. We also need to notice one thing, that oral and the VI vaccines are recommended for those over 5 years of age. Next is the treatment. So the drug of choice provided over for the enteric fever is ciprofloxacin, but in case this is resistant to the patient, we give them ceftriaxone. For carriers, we give a combination of antibacterial therapy and vaccination, so that we can eradicate this carrier state from them. However, on rare occasions, this elimination of this persistent carrier state can cause cholecystectomy, pyelolithotomy, or nephrectomy. Now, in case we have multi-resistant isolates, we can give higher dose of fluoroquinolones such as ciprofloxacin, pefloxacin, ofloxacin, and in third generation of cephalosporins, we can give them as ceftriaxone and cefotaxime. So that was the video for today. I hope you like this video. If you like this video, don't forget to like, share, and subscribe to our channel. We'll be coming with more videos. Still then, stay tuned. Happy learning. This is Ashna Viraju signing off for today. Bye.